And now have the pleasure to introduce our speaker for this week and next week. Marianne Carter is a clinical pharmacy specialist in palliative care and pain management here at UK Healthcare in Lexington. She received a Bachelor of Science in Chemistry from Purdue University in West Lafayette before graduating with a Doctor of Pharmacy and Palliative Care certificate from the University of Iowa's College of Pharmacy. Carter then completed an outpatient palliative care pharmacy fellowship at the University of Iowa, followed by a PG1 pharmacy residency at LMH Health in Lawrence, Kansas, and additional pharmacy residency in palliative care and pain management at the University of Iowa College of Pharmacy. So we are pleased and to welcome Marianne Carter with us today. So thank you. And I will turn the slides over to you.
Hopefully that doesn't happen again. Hi, everyone. Thank you for having me. I'm happy to be here. As Chris mentioned, I'm going to be talking about cancer, pain, and opioid use disorder. So kind of a broad topic base and lots to discuss. So please, if you have questions as I'm talking, shout them out or put them in the chat. And I'll also be happy to answer them next week. So first things first, I have no relevant financial relationships to disclose. And we'll start off with some practice gaps. So almost 2 million Americans were projected to be diagnosed with a new cancer in 2023, and 51% of patients with any stage of cancer experience pain. And that's any level of pain, anywhere from mild pain all the way up to moderate and, of course, severe pain. And 33% of patients will experience moderate or severe pain. And opioids, in conjunction with other analgesics and non-pharmacologic options, which we'll discuss, are an important part of pain management for patients with active cancer and those in survivorship as well. So patients with no evidence of disease after cancer treatment. And robust screening for and management of opioid use disorder is an essential part of cancer care, and good transitions of care between teams can facilitate this. And we'll talk a little bit about how that can happen. A few learning objectives for today. First, we will review the incidence of cancer in different populations, treatment options, and related adverse effects. We will outline the pillars of cancer pain management and appropriate screening tools for opioid use disorder. And we will apply knowledge of cancer care and pain management to care for patients with opioid use disorder. So first, we'll start out talking about cancer. As I said, this is kind of a 50,000-foot overview. So we'll start off a little bit with some incidents of cancer and then talk about some staging and treatment options as well. So the 2023 predicted new cancer cases are separated into men and women. So I'll start with men. Prostate cancer is the top of that list, 29% of predicted new cancer cases this year. And then followed not very closely by lung and bronchus, and then colon and rectum, urinary bladder, melanoma of the skin, and kidney and renal pelvis. As we continue through and we talk about new cancer cases in women and also in the state of Kentucky, I'll point out some overlap in these statistics and also where they differ. And then in women, breast cancer is the most commonly new diagnosed cancer, followed by lung and bronchus and colon and rectum. As with men, prostate was followed by those two as well. And then uterine corpus, which is just the uterus itself, and then melanoma of the skin as well. So overlap with men. And then I thought this was interesting. They also spread these new statistics out to look at state specific as well. So I pulled the statistics for Kentucky. So somewhat surprisingly, I would say, lung and bronchus is up at the top, followed by female breast and prostate. If you'll remember, those were kind of the most diagnosed in women and men, respectively, followed by colon and rectum and melanoma of the skin. So keep these statistics in mind as we talk through some risk factors and how there might be some overlap here. So I wanted to talk about a couple of things as they increase risk for specific cancers. There is not data on, or at least not readily findable data on opioids and their risk of cancer. So I pulled data on a couple of things, both alcohol and tobacco. So first we'll talk about alcohol. As you can see, I've got a nice little infographic from NCI that shows where alcohol might increase the risk for cancer. So mouth, throat, nose box, and esophagus. Also breast cancer in women, liver, and colon and rectum as well. So alcohol causes damage to DNA and proteins via two separate mechanisms. So first, the ethanol is metabolized into acetaldehyde, and then there is generation of reactive oxygen species. Alcohol can also impair metabolism and absorption of nutrients, and it can increase blood levels of estrogen, which makes sense as you see that it increases the risk for breast cancer. And next up is tobacco and how it can affect cancer risk. Again, I've got a nice little infographic over here at the side. As you can see, tobacco increases risk of lots of different cancers. Similarly to alcohol, mouth and throat, esophagus, and voice box. Also lung, bronchus, and trachea, and lots of different ones as well. So one thing I did want to point out is that all four of the following can increase risk of cancer: tobacco smoke, secondhand smoke, smokeless tobacco products, and electronic cigarettes. So whether or not patients are vaping or they're using dip or they're smoking cigarettes, all of those can increase risk of cancer. So just something to keep in mind, especially as we're counseling patients and thinking about harm reduction. And then I have a couple of questions throughout the presentation that I wanted to ask you all as you are caring for these populations. And as I mentioned earlier, the cancer incidence kind of varies through different populations. So I was wondering what you all think about the variance and incidence of cancers throughout the different populations. So men, women, statistics in Kentucky, and then some alcohol and tobacco as well. So I'll give you a couple seconds. You can put things in the chat or unmute, whatever is easiest.
I'm just curious. I mean, I don't know if you know this off the top of your head, but with lung and bronchus cancer being high, so I'm curious if there's just higher rates of smoking or tobacco use, and that's the likely link there with higher incidence in Kentucky. Yeah,
that was exactly what I was thinking as well. And I see that Dr. Nichols put something in the chat that the increase in lung cancer in Kentucky makes sense with the prevalence of smoking. So that's kind of what I was thinking as well, was just that there's, men and smoking. So that was kind of what stood out to me as well, just that there's a high incidence of smoking. And that's something I would say that bears out as well, working here at UK. And I'm sure for you all, as you're taking care of these populations, that's pretty striking. So that's kind of a big area where we could do some counseling, harm reduction, smoking cessation. As a pharmacist, of course, I have to make a plug for pharmacists and community pharmacists who do a lot of smoking cessation counseling and can help patients with resources. So even just from doing that, we could decrease, hopefully, the risk for cancer in our patients. So now that we know a little bit more about cancer and the incidence of cancer, so I'm just reading this in the chat. Cancer is also in my county. Oh, thank you for putting that in the chat. And I'm so sorry about your loss of your niece. But yeah, lots of tobacco production and increased risk of cancer. And thank you for sharing that. So now that we know a little bit more of the incidence of cancer and risk factors, and kind of Kentucky specific factors and incidence, I want to talk a little bit about cancer staging. So there's kind of two ways that you might see cancer staged. I wanted to start with the more specific one, and then I will show you probably the more common one that you'll see. So the first one is the TNM system. It stands for T, so the primary tumor that a patient might have, N, regional lymph nodes, and then M, distant metastasis. So for example, if your patient had lung cancer, the primary tumor would be their tumor in their lung. And then when we were doing a biopsy or trying to stage the cancer or doing surgery, they would probably take out some lymph nodes, do some biopsies on those, see if there's cancer there. And then if the lung cancer metastasized somewhere else in the body, then that could possibly qualify them for an M. I'll say this throughout the presentation, but especially here, it is very specific to the cancer type that you have. So a lot of this comes from a set of guidelines called NCCN. Those are kind of the gold standards for cancer treatment, and also risk and prevention and management of side effects, things like pain we'll talk about in a little bit. But it's very specific to whether you have breast cancer or liver cancer or colon cancer. And each one of them has different staging criteria. So this is very broad. And then the way that this is used to stage, there's kind of different numbers or an X that can go along with it. So X cannot be measured. There's not enough information. 0 cannot be found. And then 1 to 4, higher number means more disease, likely further away from the primary tumor. So an example would be T3N1M0. So T3 means your primary tumor is pretty big. N1 means that you've got some lymph nodes that are positive. M0 means there is no distant metastasis. So if you're reading notes in a patient's chart, or you see this anywhere, that's kind of what this means. Again, it goes along with the cancer type. So that would definitely be something to look up or ask about, but just some more information about how we stage it and figure out how we're going to treat it. And then I also wanted to talk about the more common stages, so 0 through 4. So 0, abnormal cells, but no spread to nearby tissue. So not officially cancer. And then stage 1, 2, and 3, cancer is there. Higher numbers mean larger primary tumor and spread to nearby tissues. And then stage 4, the cancer has spread to distant parts of the body. So as you can see, this kind of matches up with the TNM scenario. So stage 4 would be that M is a 1, which means there is distant metastasis. And then 1, 2, and 3 are very variable, and stage 0 would be not cancer, but kind of pre-cancerous. And then in terms of this, so talking about stage 0 to 1, as you can probably expect, the higher stage cancers mean different treatment options and different treatment goals. So I wanted to talk a little bit about treatment intent, as this will come up as you're caring for these patients. So there's kind of two ways that it could go. The first is curative. So we want to completely eliminate the cancer, stop or slow the growth. And then in a palliative treatment intent, we're kind of focusing on quality of life and symptoms in a later stage cancer. So these patients who have a palliative intent of treatment can still be receiving treatment, are still receiving treatment. But the goal is not to eradicate the cancer. The goal is not to say that they are cancer free. It is to make them feel better and have a better quality of life and be able to complete their ADLs. But it doesn't necessarily mean that we think that they are going to be able to get rid of the cancer. Curative intent, and again, broad generalizations, but typically for lower stage cancers, we can more easily cure them, we can cure them. And then the higher stage cancers, we kind of move more into a palliative approach. And then I want to talk a little bit about some treatment options for cancer. And again, a lot of this is very specific to the type of cancer and the location of cancer and the stage of the cancer. But there are lots of options, as you can see. Everyone has probably heard of chemotherapy. This is meant to be, it targets really all cell types, including the cancer. and fast-growing cells, which we'll talk about as we talk about side effects of treatment. But it's not specific to the cancer itself. And then immunotherapy utilizes your immune system to fight the cancer. So it kind of revs up your immune system so it attacks something that is not inherently you or your body. Targeted therapy finds and attacks certain types of cancer cells, so it's more specific to the cancer itself. And then hormone therapy can be more common in things like breast and prostate cancer. As I talked about, alcohol use can increase estrogen levels, which can affect breast cancer risk. So hormones can be useful there in patients who have breast or prostate cancer to help mitigate the hormones and their effects. Also things like radiation therapy and surgery, these are really dependent on the type of cancer, where the tumor might be in the body. If it's accessible, if we can give these types of therapies. Radiation is dependent on how much radiation you've had before. So if you have a patient who has had cancer for a very long time, has been receiving treatment for a very long time, they might have received a lot of radiation, which comes into effect as we don't want to expose our patients to too much radiation. And then last but not least is stem cell or bone marrow transplant. This can be for patients who have things like leukemia, lymphomas, or myelomas, so blood cancers. And there's a lot that comes along with stem cell transplants and bone marrow transplants, a lot of immunosuppression, a lot of medications, a lot of really close follow-up that I won't get into specifically, but it's very time intensive and healthcare system intensive. And I wanted to talk a little bit about the duration of treatment and follow-up. Again, same caveat, this totally depends on the type of cancer and the stage of cancer and what kinds of treatments our patients are receiving. And this can be weeks to months or even years. So a typical, again, very dependent, but maybe like a 6-week chemotherapy cycle or a 6 treatment cycle treatment plan, and there's maybe 3 weeks to a treatment cycle. So that would be 18 weeks that your patient might be receiving chemotherapy. And then they will have follow-up with their oncologist, which I'll talk about as well. They'll need imaging to evaluate the treatment efficacy and a change in clinical status as well. If your patient comes in and they're very sick and we're not necessarily expecting that. Imaging is kind of really the first line of defense to figure out what's going on. And of course, labs too. And then, like I said, frequent follow-up appointments with the oncologist and other specialists. Of course, I have to make a plug for palliative care since I specialize in palliative care. But there are lots of specialists that go along with oncology care. And even in the oncology clinic, lots of people that they can see could be nutrition, could be social workers. Of course, they're going to see nurses. They're going to be counseled by pharmacists. Just a lot of intensive time and follow-up and travel, and can be very life disrupting. So with that lead in, I wanted to ask you all, what issues do you foresee for patients with concurrent cancer and opioid use disorder diagnoses? And more specifically, patients who might be on MOUD for opioid use disorder.
I think that probably pain management would be a big barrier for people. My aunt has stage 3 lung cancer, so I know that she's in a lot of pain a lot of times, and them not being able to get what they need.
Yes, I agree with you, and thank you for sharing. That is something that we will talk about later on in the presentation. I agree with you. That is definitely something that is a barrier. Poor computer is just not having it today. I'm so sorry. And then Dr. Nichols has had some great input in the chat, talking more about the palliative intent of treatment and its chronicity. And also just mentioned pharmacies don't always fill opioids for cancer pain to people who were on MOUD. And that is an excellent point. That's something that we run into and talk about a lot on our team, especially in our outpatient clinic, and something that we talk about in the community that requires a lot of counseling for other care teams who are taking care of these patients, and for the pharmacies themselves and the pharmacists, and that can be time intensive as well. Yep, and then I also see cancer patients in the pharmacy whose pain is not adequately treated to a tolerable level. So yes, pain management is a big deal and something we'll talk more about. All right, so let's talk about some cancer treatment adverse effects. So I will go through kind of a long list of possible adverse effects, and then I'll alert you to some trends in them as well. So things like fatigue, confusion, anxiety and/or depression, not necessarily just related to the cancer treatment itself, but also to the fact that they have this huge diagnosis, hair loss, skin rash, nausea and vomiting, mucositis, loss of appetite, change in taste or smell, diarrhea and constipation, urinary retention or incontinence, anemia, thrombocytopenia, or neutropenia, so changes in your blood counts, lowering of your blood counts. And then last but not least, pain, as we talked about. So a couple of trends here, as I mentioned, chemotherapy hits at fast-growing cells, so that includes the cancer, but it also includes other fast-growing cells in your body. So that can be things like your blood. So I mentioned lowering of kind of your blood counts across the board. Also your skin. So we counsel patients to make sure your skin is moisturized, protected from the elements, lots of sunscreen, things like that. As you can see, skin rash is a possibility. Hair loss. Our hair qualifies as one of those kind of fast-growing areas. So hair loss is a really common thing that patients experience when they're receiving chemotherapy. And then also just changes to your GI system. So a lot of these things, mucositis, nausea and vomiting, which is a common thing that we are consulted for, especially on the inpatient team, and that's really hard to treat. Diarrhea and constipation. And I would also say, kind of similarly, loss of appetite or change in taste or smell. The chemotherapy itself can affect the way that things taste to you. So if you receive a platinum-based agent, things can taste metallic. And that can be really disconcerting for patients and something that we try to help with, but isn't always possible. So as you can see, there's lots of changes, lots of side effects to deal with, lots of things that our patients are experiencing. And then I wanted to talk as well, of course, on the palliative care side, we see patients who are very sick and who often have really advanced stages of cancer. But I wanted to talk too about the survival rate, because lots of patients who have cancer successfully receive treatment, go into remission, and just have to be followed longitudinally for kind of check-ins. So prostate and breast, the 5-year survival rates, these are 5-year rates, are up in the 90s. Those are the most commonly diagnosed cancers in men and women, as we talked about. And then as you can see, going down lots of cancers with 60 and 70% 5-year survival rates that are very treatable, depending on the stage and the location, as we always talked about. And then in all cancer sites, the 5-year survival rate is 68%. And the range is anywhere from 12% to 98%, as we talked about with prostate cancer is 97%, thyroid cancer is 98%, and then 12% is pancreatic cancer. It is typically diagnosed late stage based on symptoms, so it's very hard to treat and get back on top of it. And then I also want to talk a little bit about cancer screening and early detection. There are 4 cancer types that have published guidelines on screening and early detection methods. So breast, of course, is a big one. Patients with average risk, so family history and personal history, are low for indicating that they might be at an increased risk of cancer. When they're 40 or older, they start mammograms. Colorectal cancer, as I'm sure you all know as well, is very big in terms of screening and early detection. So the guidelines now say at 45 years old, patients should start either, depending on risk, this is low risk patients, but colonoscopies, they have kits now where you can send a stool sample off to a lab and they will test it. If you're low risk, that's something that can be an option. Prostate cancer is kind of a risk benefit analysis and also based on some testing. There are some labs that we can do to tell us kind of your risk for prostate cancer. And also lung cancer. Again, this one is risk assessment based, kind of based on your personal and family history. So as we talked about earlier, things like smoking can increase your risk of lung cancer, and that would probably put you in a higher risk category, which means some extra screening. Yes, thank you, Dr. Nichols. She mentioned daily dosing and OTPs can be tough for patients who are getting chemo. I agree with you. And that's something we're going to start getting into now as we move on from kind of the big overview of cancer and how we might treat it and some risk increasing factors. And now we'll start to talk a little bit about pain. So these are called the 5 A's. These are the goals of pain management in cancer. First one is analgesia. So we want to optimize this in our patients, optimize their pain management, make them feel as good as we can. Activities. So we want to optimize their activities of daily living. Adverse effects. We want to minimize these as much as we possibly can. Aberrant behavior. So we want to monitor for the risk of possible misuse. I'll talk a little bit about that. And also effect. So relationships between pain and mood. So kind of lots of things that we're balancing as we manage patients' pain, not just medication related. Lots of them are. Lots of these come into our daily practice as palliative care professionals, but also lots of other things that can be mitigated as well. So we'll talk a little bit about those. Before we get into more of the physical pain, I wanted to talk a little bit about the concept of total pain. We think about this a lot in our everyday work in palliative care. So total pain includes social, psychological, spiritual, and physical pain. On our team, we work on an interprofessional team. So we have social workers, nurses, chaplain, nurse practitioners, physicians, pharmacists. There's a lot of us that practice on this team. And depending on our patient's needs, different people on our team will get involved. So our chaplain does an excellent job of helping with spiritual pain and helping to assess our patients. Psychological pain, our clinical social worker is excellent at kind of assessing these social pain, psychological pain things, social pain, family situation, living situation, and then also the physical pain that we as pharmacists talk about a lot and kind of the most. But I did want to point out there's lots of things that can really affect pain. Often these patients have, as I mentioned, anxiety and depression. They have a difficult family situation. They have an unstable living situation. That also affects the pain that they feel and how we manage their pain and take best care of them. And as we're talking about cancer-related pain, there are kind of 3 categories to keep in mind. So acute cancer-related pain is usually severe and comes on quickly and lasts for a short time. Chronic pain is pain lasting for more than 3 months. And then breakthrough pain is sudden, intense pain flares that occur while taking medications for chronic pain. So this would be patients who are well treated on maybe a long-acting and a short-acting opioid or MOUD and a breakthrough opioid. And they're experiencing these really intense peaks in their pain that are really difficult to treat. Breakthrough cancer-related pain is one of the toughest things to treat. We can help with acute pain. We do all the time. Patients who are admitted kind of with a change in status or something that might have happened or a procedure, and we can help them through that in the short term and come up with a good long-term plan. And lots of patients with pain have chronic pain. And I want to point out too, as I mentioned earlier, this isn't just patients who have active cancer, patients who are in survivorship, so no evidence of disease. And their cancer has been treated well can also experience chronic pain. So in terms of pain management, there are kind of two categories I want to talk about. So first is non-pharmacologic pain management. So first is cognitive modalities. So things like cognitive behavioral therapy or CBT, mindfulness-based stress reduction or MBSR, biofeedback, etc. There's varying data for these in different types of cancer-related pain, but overall, fairly positive. These kinds of things can sometimes be cost or resource prohibitive. So if they're not available in the community or the patient's insurance doesn't cover them, they might not be options, but for patients who can afford them, whether through insurance or out of pocket, they could be good options. Spiritual care as well, as I mentioned. We have a chaplain on our palliative care team. There are chaplains throughout the hospital. This is a very important part of our patients' care to make sure that we're taking care of them as a whole person and providing holistic care and not just focusing on their labs or their scans or kind of what's happening acutely in the hospital. Physical modalities as well. So this can include things like massage, heat or ice, transcutaneous electrical nerve stimulator or TENS or acupuncture. Again, as you can probably guess, maybe a TENS unit or acupuncture could be cost prohibitive, so something to keep in mind. But massage and heat and ice can be really good modalities. And then also nutritional modalities could be part of non-pharmacologic management. And next I want to talk about multimodal analgesia. So this is kind of the biggest thing that will affect patients who are on MOUD, and also kind of the biggest part of my job as a pharmacist on this team and what I see on an everyday basis. So I'll go down the whole list, and then at the end, I'll talk a little bit about kind of different types of pain. So first is acetaminophen or Tylenol. We often have patients take this regularly throughout the day. The data is not great on its help with cancer-related pain, but it's kind of a low cost, most often low risk option that we can use to work together with the opioids that are kind of the mainstay of our cancer-related pain management. Non-steroidal anti-inflammatory drugs or NSAIDs can be very helpful for patients who are having kind of inflammatory type pain or maybe who just had a procedure and they're far enough out that they could receive this type of treatment. Things like muscle aches and pains, bone aches and pains respond really well to NSAIDs. This one is more dependent on their blood counts, making sure that their blood counts are good enough and not low so that we can use these. Antidepressants, so two that are most common in cancer-related pain management would be serotonin and norepinephrine reuptake inhibitors, SNRIs. Cymbalta or duloxetine is kind of our mainstay in this category. And then tricyclic antidepressants or TCAs. This would be things like amitriptyline or nortriptyline. These can be very helpful with neuropathic cancer-related pain, especially something called chemotherapy-induced peripheral neuropathy, so pain in hands and feet. It shows up as kind of glove and stocking presentation. SNRIs are kind of the mainstay for treatment for that, and also TCAs can be considered. Again, for neuropathic pain, anticonvulsants, so gabapentin and pregabalin are things that we use a lot to help our patients who are experiencing neuropathic pain. Topical agents, this can be widely variable, things like diclofenac or Voltaren gel is common. We can also use, again, possibly cost prohibitive, but ketamine creams can be helpful for neuropathic pains. Lidocaine patches for maybe a back pain, lidocaine creams, things like that. Corticosteroids, again, for that kind of inflammatory mediated pain. And then one of our mainstays of therapy is opioids for cancer-related pain. I will say, I'll talk about a couple of more acute kind of during hospitalization pain management tactics. But this is a pretty extensive list, and we focus on multimodal analgesia. So what I mean when I say that is that we try to implement different mechanisms to target pain as well as we can. So we wouldn't just necessarily use opioids. We would also maybe use an antidepressant and gabapentin and Tylenol as well to hit different types of pains and also to work together to treat pain as well as we can. Often patients have lots of different types of pain. Neuropathic pain is extremely common. Lots of additionally achy type pains, like I said, bone and muscle pains, lots of abdominal pain. So often it's not just kind of one presentation that we say opioids will help with this, and that's all we use. Patients have widely variable pains. So hopefully when you see patients' medication lists, you'll see that we're kind of using lots of different tactics. And then I also wanted to talk about a couple of things that we use in the hospital. For severe acute uncontrolled pain, we can use IV ketamine or IV lidocaine as well. We use a lot of IV ketamine here at UK, can be very helpful for neuropathic pain. Can also help patients who are maybe having different pain responses that we would expect. So something that we wouldn't expect to be painful and is painful, to kind of help reset that pain response. And IV lidocaine can be used for severe neuropathic pain as well. Okay, I want to take a short break here and ask if you guys have any questions at the moment. Of course, you can submit them and we can talk about them next week or at the end. But if you have any questions right now, I'll take those. All right, I'll keep moving. If you have questions or thoughts that come up, please put them in the chat or unmute. So next, I'll talk a little bit about opioid use disorder and kind of wrap up how cancer and cancer pain management can affect patients who have opioid use disorder. So as we talked about, a big part of cancer care in general, but of course, with patients who also have opioid use disorder, is risk mitigation. So there are a few strategies that come into effect here. Comprehensive history is really important, medical, psychiatric, and also substance use history. Screening, which we'll talk a little bit about. Counseling about opioids and safe storage and disposal. Review of the Prescription Drug Monitoring Program, or CASPR, in Kentucky. Urine drug screens, and also frequent reassessments. So a lot of these things will happen in a clinic setting as they're receiving care. So an oncology clinic or in a palliative care clinic. Often there will be policies for prescribing opioid medications that include a lot of these things. So talking about taking opioids, what are the short-term side effects? What are the long-term side effects? When we change your dose, how might that affect how you feel? How might they interact with other medications or things like alcohol? And then also safe storage and disposal, making sure that if there's a change in medication or patients no longer need their medication, that they have a way to get rid of it safely. We, on the palliative care service especially, but also in oncology, often review the CASPR on all of our patients to see what they've been using on the outpatient side, what they've been needing for their cancer-related pain. One thing I do want to point out is that when patients are receiving methadone through a methadone clinic, it does not show up on their CASPR. So we have to call the clinic directly to verify their dose. Urine drug screens can be a helpful part of treatment agreements on the outpatient side. And then also screening, which I mentioned. So we'll talk a little bit about that and a couple of tools that we use in palliative care to help assess patients' risk for an opioid use disorder. So one of them is the screener for opioid assessment and patients with pain, or the SOAP SF. SF means short form. So there's 5 questions. How often do you have mood swings? How often do you smoke a cigarette within an hour after you wake up? How often have you taken medication other than the way that it was prescribed? How often have you used illegal drugs, for example, marijuana or cocaine, in the past 5 years? And then how often in your lifetime have you had legal problems or been arrested? And there's a number scale to answer these questions, and based on the number that you answer, it puts you into a risk category. And this can be part of screening and taking care of these patients, and kind of what their follow-up might look like, and how often we check in with them or get a urine drug screen. And I wanted to talk about another option as well. So this is called the Opioid Risk Tool Revised. I know in a previous presentation, Dr. Nichols talked a little bit about this, but there's a lot of different categories, including family history of substance use, personal history of substance use disorder, and then also psychological disease. And again, based on your yes or no's and where you fall, that puts you into a risk category. And higher numbers for both of these mean that you're at a higher risk for a use disorder. And then my last question for you guys during this presentation is, how do you think different living situations might affect patients with cancer who are receiving treatment for opioid use disorder? So whether they are, living at home, or they are experiencing houselessness, or they're in a sober living facility, how do you think that might affect both their cancer care and also their opioid use disorder care? Yes, thank you for your clarification, Dr. Nichols. So these are screening tools used to not prescribe. These are not screening to not prescribe appropriate opioid pain medication. So that means that we screen patients and we assess their risk, but also we make sure that we prescribe safely for them and that they are receiving opioid medications for their cancer-related pain. And I'll talk a little bit about how that works together with their MOUD treatment as well. So thank you for clarifying that. Patients who are at higher risk for use disorder based on the screening tools, that doesn't mean that they don't get opioids. They still receive appropriate and safe treatment for their cancer-related pain.
This is Katrina Nichols, just thinking about the different living situations, and maybe for next week, a conversation, but one living situation that's come up here at the Cancer Center is when people are living in sober living communities, and sometimes there's mandated like other treatment or number of sessions that they need to be present in the sober living house. But, chemotherapy infusions can last all day, especially if they're also coming in every day for like radiation for head and neck cancer. And so that impacts or can negatively impact them having a disruption in their treatment for their substance use disorder, because they can no longer live in that situation. And then they're experiencing homelessness. That's one situation that I found really difficult to navigate as a provider, and haven't found great answers that my patients have been able to find in that situation.
Yes, thank you for that input. That's an excellent point. And something that I didn't fully expound on when I was talking about cancer treatment is, as Dr. Nichols mentioned, it can take all day. There can be multiple treatment days in a week, multiple treatment days in a month. You can have an oncologist appointment before and then treatment. You can have an oncologist appointment on a different day, depending on the clinic schedule. It's very time intensive and also transportation intensive. Maybe patients with different living situations don't have great transportation opportunities or options at their disposal, or they have a specific schedule in which they can get transportation, and that can really affect the care that they can receive and how all of this works together. So to wrap up, I want to talk a little bit about options for MOUD and how they fit into cancer care and specifically cancer pain management. Yes, and thank you for the input in the chat. People in home incarceration would need a change in court orders to receive treatment. And that is a huge barrier and something that can affect care all around in all different settings for all different disease states. So a quick review in terms of opioids. So buprenorphine is a partial agonist, high binding affinity at the mu opioid receptors, and methadone is a full agonist. So these medications, of course, can be used for MOUD, but they are still opioids, and they fit into the cancer pain management lexicon. And they also fit into the plans that we make as palliative care and also oncologists and other providers, and how we treat their pain. So some acute pain management strategies when patients are on either buprenorphine or methadone to manage their OUD. The first is an adjustment in dosing schedule. So MOUD is commonly dosed once a day due to long half-life, but the analgesic effects usually last for 6 to 12 hours. Methadone is 6 to 12 and buprenorphine is a little shorter at 6 to 8 hours. So when patients are experiencing acute pain related to their cancer, often we will split dose them at 6 to 8 hour or 12-hour intervals for acute pain. So if a patient was receiving, say, 120 milligrams of methadone in the morning from their methadone clinic, when they come into the hospital with an acute pain, maybe we would dose it 40 milligrams every 8 hours. Still the same total daily dose, still the treatment dose they were receiving, but it's a little split up. And as a pharmacist on this team and our providers as well, I communicate with their clinics to make sure that this dosing strategy, that they know that this has happened in the hospital, and that we change their dosing strategy a little bit, but that it's the same dose. And I work with them to make sure that that is okay and that that will not affect the patient going back to their treatment center once they're discharged. And then also something to keep in mind as I was talking about screening tools and how we prescribe opioids for these patients, immediate release opioids, possibly at higher doses than is typical. So whatever a typical dose is for a patient, maybe typically a patient would need oxycodone 5 milligrams, for example. Maybe these patients need 10 milligrams because their tolerance is higher and they already have opioids in their system. Would be appropriate if the split dosing is not adequate. So typically on especially the inpatient side, we do split dosing and a short acting opioid on top of that to get them through kind of their acute pain, and then make sure that they have adequate outpatient follow-up, both for their MOUD and also for their cancer pain management, so that we can continue that on the outpatient side. And as we're talking about methadone as well, and possibly daily dosing at a clinic, that can also be prohibitive for patients who have to go and receive cancer care, who have treatments and doctor's appointments. That affects the time of day that they can be seen. Those could be very long days for them. Transportation can be difficult, so something else to consider for these patients as well. And then I also wanted to mention naltrexone, specifically extended release IM naltrexone or Vivitrol. So naltrexone completely and competitively blocks effects of full agonist opioids at the mu receptors for 28 days. So it's a depot effect. Patients receive the shot once every 4 weeks. So some strategies to manage with naltrexone would be to focus on the non-opioid analgesics that I talked about. So I mentioned IV ketamine and lidocaine, and also interventional pain procedures. So sending another referral, which can be difficult too, for patients to be seen elsewhere and see if they can get a block or a pain pump or something like that. Another strategy that's not an opioid for an acute pain. And they might require high dose full agonist opioids and or a rotation to an opioid agonist MOUD. So rotation to buprenorphine or methadone away from naltrexone if we can't adequately manage their pain and come up with a good management strategy. So just a couple of considerations with the medications that you guys see all the time, and kind of the things that we think about when we're managing cancer pain in patients who are on MOUD, and making sure that everything works together well, because I don't want to recommend a treatment plan that is not sustainable and that would be detrimental to our patients and the other care that they're receiving. So these are things that are running in the back of my mind all the time. So a couple of key takeaways. Cancer incidence, as I mentioned, varies across different populations, and treatment options are based on many factors. including cancer type and staging. Pain is a common symptom of cancer and cancer treatment, and both non-pharmacologic and pharmacologic management strategies can help to mitigate these symptoms. Risk mitigation is a necessary part of opioid prescribing for all patients with cancer. However, it is especially important for patients with a concurrent opioid use disorder. And patients with cancer and opioid use disorder should remain on treatment for OUD while receiving treatment for cancer. Like I said, I am taking into account everything that they are receiving in terms of care, and I never want to affect the care that they're receiving for opioid use disorder with what I am doing. So we focus on a co-management strategy, that they are still receiving treatment for their opioid use disorder while they are receiving treatment for cancer and cancer-related pain too. Next up are my references. So I was wondering what questions and thoughts you all have.
I have a question. Did you say how you would dose like somebody that's on buprenorphine? Like if they were using that as pain management or whatever, they were on that for their SUD, how would you dose that for somebody?
Yes, great question. So let's say they are on 16 milligrams once a day of Suboxone. We could do 8 milligrams twice a day. Or if they're on 24, we could do 8 milligrams every 8 hours. So we would split dose it similarly. And then, like I said, checking in with their MOUD providers and letting them know what we've been doing while they've been hospitalized, and also how that affects their care on outpatient as well, to make sure that they are receiving good care for their opioid use disorder, that we are managing that well, consulting addiction medicine on the inpatient side, and making sure that we have good handoff for when they go back to their providers and clinics.
I have a question about the methadone, or thinking about methadone dosing, or splitting dosing in, is if that's really only available in an inpatient setting, or how you try to manage that upon discharge. Just because I imagine with OTPs only open, at their dosing hours, that unless the person has take homes or something like that, it would be very difficult to still do that post discharge. So I'm just curious if you have experienced that or can speak to that.
And I'll invite Dr. Nichols to give her input as well. So we actually did just recently experience this with a patient that we were assisting with pain management. And while they were here and we were actively managing pain, we split their methadone dose. I think it was 120 milligrams. So we split it up to 40 milligrams Q8 hours. I called their methadone clinic, let them know that, and they said, we can't provide split day dosing while he's here, while he's outpatient and receiving treatment in the clinic. But we acknowledge that that's a great pain management strategy. And we are okay with you doing that as long as you can provide us the medication record to show that he was receiving his total daily dose every day. So yes, that is an excellent point, that typically when they leave the hospital and go back to their MOUD providers, that they go back to their once daily dosing.
Yeah, so it depends on the patient and it depends on the clinic. So depending on how long they've been there, if they already have take-home doses, some clinics will allow like at least twice a day. But if they're very early in the program and maybe they are in early remission of their opioid use disorder, that's challenging. A lot of the OTPs won't deviate from what they're used to. So it's been very challenging to try to find a great discharge plan when people come in with severe cancer pain. And not all procedures done to treat the pain are completely done by the time they're ready to be discharged. There are successful cases where we can get radiation or a resection of the painful tumor or things like that. So it is short-lived, but when it's going to be longer for weeks, it's really challenging. And so then it just becomes kind of a harm reduction approach of where this person is at, what's going to be a way that they can get their medication with the least amount of harm and risk. And so it's very challenging, and especially with the regulations as well. So there's not a great answer. And so like applause to everyone who's working with your patients and clients individually to really help them navigate when this comes up, of how challenging it is to get effective pain management when they're on treatment for their opioid use disorder.
I'm just going to read some others. Feel free, of course, to come off mute. I'm just going to read what I saw come in the chat, and also a reminder, if you prefer to anonymously, you're welcome to send a direct message. But one that just came through: would it be feasible to send patients home with a script for additional daily doses they would need in addition to the scheduled dose at a clinic for cancer pain? It sounds like maybe morphine.
I'll answer this, and hopefully I cover this. If this does not cover your question, please either unmute or put in the chat. So for patients who are established with a methadone clinic, we communicate with their methadone clinic and do as much as we can to get them back there. So we will do as much as we can to let their MOUD providers continue to manage that. So we, especially as they discharge from the hospital, typically do not write prescriptions for additional daily doses. But if they are receiving care at a clinic and receiving daily doses of methadone, and they require immediate release opioids on top of either their methadone or buprenorphine, then we can write prescriptions for that and make sure that they have adequate follow-up outpatient for that.
And the other part, the thing that makes very difficult with a methadone, and someone's brought this up, is not only like the prescription and with the, the physician writing the prescription and the pharmacies filling the prescription. So not even just the medication, but also just the process at opioid treatment programs with like the random callbacks for and random urine tests, or some places still have like mandated counseling. It's very challenging for people who can have severe side effects of their cancer treatment or just of their cancer. Like nausea and vomiting isn't always just the day of infusion. Sometimes it's delayed and it's the week later. But if they're missing those appointments, then they're considered being not adherent to the treatment plan. Or if they miss coming in, if they've got take-home dose, if they miss coming in for, med counts. And so, we have to do a lot, not just from a prescribing end and pharmacology end on discharge planning from the hospital, of having like clear communication with the treatment team at the clinic so that they can understand that and understand what the treatment plan is going to look like from the cancer treatment perspective, so that they're aware of that, so that if the patient's not answering the phone or coming in, that there could be a reasonable answer that it's just that they don't feel well. And so it does take communication to that effect. And so it's very complicated.
I saw another comment in the chat: when methadone is used for pain only, not opioid use disorder, it is dispensed from a pharmacy like a normal medication. So changing regulations around OTPs would be very helpful for these patients. Yes. Yes, it would. And it's very, very complex. And I mean, to Dr. Nichols' point, it's so much of it is communication and scheduling and coordination. And it's a lot of moving parts for these patients.
And then even for buprenorphine regulations, at least in Kentucky, it's only supposed to be once daily. But, because it's picked up at a pharmacy and the patients, have that, then they can split their dose. But with methadone having to be directly observed and there's your dose, you can't do that unless you have like also a nighttime split dose. If you've been in treatment for a while for them to do that for you.
Thank you all for clarifying. Yeah, I was just going to try to point out, hopefully that was clear to everyone that the differences there, specifically, that methadone, it has to typically from an OTP when being used for opioid use disorder has to be dispensed directly from there. So there can't be a prescription for it or can't pick it up at the pharmacy to do any of those split dose things. And I did just want to make a point regarding regulations for anyone who is interested, and I'm happy, I'll try to find the link and send it before we end if possible, but if not, can share it next week. The regulations regarding OTPs, there's no statement regarding a change, of course, for the actual dispensing, but there is some potential wording that those are open for public comment that talks about just basically individualizing or if there is a what maybe would have previously been considered an infraction or like a miss or things like that, where you would have had to kind of start over in your phases, that there could be maybe potentially a little bit more leniency, and again, individualizing and understanding the discretion. So perhaps there would be more space for people who, have these additional considerations, such as what they're going through for cancer treatment, that might make say missing an appointment or take homes or something like that potentially more feasible. So just if anybody's interested in seeing the regulations or making public comments that are in support of some of those language changes, again, I'm happy to try to find that link and put it in the chat.